So, welcome to today's webinar. So, today we'll be discussing about follow-up of high-risk newborns. So, before I hand it over to Dr. Lekshmi, who will be presenting, followed by the discussion. If you see how the neonatology has evolved, it started from primarily intensive care after the death of Kennedy's baby, and the initial focus was primarily to improve the care to make the babies survive, because making them survive was a big challenge in the earlier years. Then gradually people started thinking that now their survival rate has improved. They need to improve their intact survival also. So then people started thinking on two lines. One is, so they looked at both the tails. On one tail is entering into the labor room area. So they started focusing on improving the labor room practices. And now in last 10 years, you know that how much research work has been done in this area to improve the care of both term and preterms, and the own data from our own country from Dr. Ramji really showed delayed cord clamping, room air resuscitation and all that. So people were working in this direction to improve the survival and intact survival. On other side, we have to move further forward. After saving these babies in ICU, we need to follow them. We need to follow them to improve their survival. And there, the credit goes to Arun sir, and he proposed the concept of early intervention center throughout India. And that's a unique kind of concept. So which means that if we have to improve, we need to focus on both the areas, whether it is delivery room and whether it is early intervention. So truly speaking, early intervention center is not a separate area. It should be considered as a part of your NICU only, where you can follow these babies who are at high risk for a lot of neurodevelopmental disability and improve their outcomes. And if you ask me, till now, whatever has been done in terms of follow-up, primarily the people have focused only on the growth and the brain, the neurodevelopmental aspect. But to me, it looks like that, imagine yourself as a father or parents of a child who is premature. What you want to your child to be. You want that your child is not only intact in terms of the brain growth, in terms of the development, but what about other organs? What about lungs? If he is going to suffer from reactive airway disease, recurrent infections, then what is the fun of that? That lungs is also going to affect your brain. If the kidneys are not normal, if the endocrine system is not normal. So, but I think to me it looks like that if you further go one step forward, then in this early intervention center we should include these aspects also to achieve the intact survival. Intact survival doesn't mean only the brain. I think it is a holistic approach we should follow. So having said that, I would invite Dr. Lekshmi to go ahead with the presentation. Dr. Lekshmi, please.
More than 97 settle, not IUG, but less than third settle. The slide about the objectives of today's presentation, high-risk newborn follow-up. First of all, we'll be seeing why high-risk newborn follow-up is required, data regarding the importance of structured program and early intervention programs. Then who all requires follow-up, who all are the people involved in follow-up, when and where it should be done, and how follow-up can be done. This is the first slide where we have a data regarding, it is a systematic review where it is said that, where it was found that there was high prevalence of long-term neurodevelopmental sequelae, including learning difficulties, developmental delay, epilepsy, cerebral palsy, hearing and vision impairments in high-risk newborns. You can see in babies who had sepsis, 40% of the babies who had sepsis had neurodevelopmental sequelae. And 42% of babies with meningitis, 31% of HIE babies, 31% of preterm babies, and 41% of babies who had CNV had neurodevelopmental sequelae in long-term follow-up. Hence, appropriate follow-up is required for early detection and management of any morbidity associated with perinatal events. Now, with advancement in neonatal care over the years, like Neeraj sir has said, mortality has come down a lot. Even the morbidity has come down, but still there is a lag in corresponding fall in mortality. It is shown in this graph that you can see mortality is decreasing, morbidity is also decreasing, but there is a significant gap between the two. This is an Indian data which is showing neurodevelopmental outcome of high-risk newborns, and it was found that 31.6% of the high-risk newborns discharged had a prevalence of neurodevelopmental delay, and it was significantly higher in low birth weight and preterm babies. This is another evidence where at 18 years of age, babies NICU graduates were followed up, and it was found that early intervention programs which were starting in NICU had positive influence in cognitive and motor development. This is a randomized controlled trial where intervention was done as an early intervention. The intervention group had early intervention, and it was found that they had higher cognitive developmental scores in long-term follow-up. And this is again another data where at 8 years of age, babies were followed up, and in this also it was found that babies had better cognitive and academic skills if they had early intervention starting from NICU itself. Now, to summarize, why is follow-up important? First, obviously for surveillance to detect any deviation of growth, development, or behavior from normal, and to start early intervention. It can be also used as a benchmarking to audit perinatal data, and it also helps, and the data will also help in anticipatory counseling to have a retrospective analysis of the procedures and of the treatment that was given in NICU in the perinatal period, and also for health planning. Now, to define high-risk babies, to define the babies who need follow-up, they can be divided into babies with high risk, moderate risk, and mild risk. High-risk newborns are those belonging to extremely low birth weight less than 1 kg, at gestation less than 28 weeks, babies with major comorbidities including chronic lung disease, IVH or PVL, babies with perinatal asphyxia, with surgical conditions like congenital diaphragmatic hernia or TEF, babies who were small for date, less than 3rd centile, or large for date, more than 97th centile, babies who required mechanical ventilation for more than 24 hours. Previously it was 48 hours, currently it is more than 24 hours. Persistent prolonged hypoglycemia or hypocalcemia, babies who had seizures, meningitis, who had shock requiring inotropic or vasopressor support, infants born to HIV positive mothers, babies with twin-to-twin transfusion, babies who had neonatal bilirubin encephalopathy, babies with major malformations, with any evidence of inborn errors of metabolism or other genetic disorders, or abnormal neurological examination at discharge. These babies require a stringent follow-up, and this is moderate babies belonging to moderate risk are very low birth weight or gestation less than 33 weeks, twins or triplet babies, babies with moderate neonatal HIE, hypoglycemia with blood sugar less than 25 mg per deciliter, babies who had neonatal sepsis, babies who had hyperbilirubinemia with more than 20 mg per deciliter or requirement of exchange transfusion, IVH grade 2, and suboptimal home environment. And those with a mild risk include preterm. All preterm babies belong to mild risk. Low birth weight babies, HIE grade 1, babies with transient hypoglycemia, suspected sepsis, neonatal jaundice requiring phototherapy, and IVH grade 1. Now, coming to the next objective, how to follow up. First, we have to see the prerequisites for follow-up, what all are required for follow-up, how frequently we should follow up, and what all are to be done, what are the steps to be done in a follow-up visit. We'll be seeing it in the next few slides. And discharge planning, that is the prerequisites for follow-up. The following criteria should be fulfilled for every discharge. The baby has to be hemodynamically stable. He should be able to maintain body temperature in an open crib. Baby should be on full enteral feed, either direct breastfeeding or palliative or spoon feeding. Parents should be confident about to take care of the baby. Baby should have crossed birth weight, and there should be consistent weight gain for at least 3 consecutive days. For very low birth weight babies, that is less than 1,500 gram, weight should be at least 1,600 gram before discharge. Baby should not be on any medication except for vitamins and iron supplementation for preterm babies. And preterm babies who are on theophylline or caffeine therapy for apnea of prematurity, they should be off therapy for at least 5 days to make sure that there is no recurrence. And vaccination as per should be given to the baby, and vaccination is according to postnatal age. We'll be coming to that later. And prior to discharge, we have to give a proper counseling to the family. Family sensitization should be done. They should understand the requirement of follow-up, and we should be explaining them regarding temperature regulation, proper clothing, caps, socks, etc., regarding feeding, regarding prevention of infection, hand washing, avoidance of visitors, etc., regarding the next follow-up visits, when and where they are happening, and the danger signs. They should be explained regarding vaccination, special needs, example, next ROP visit, USG, MRI, brain, etc. And if possible, the family should be provided with a telephone number of a healthcare provider to contact in case of emergency, which we are doing here. When to follow up? This is the minimum requirement of follow-up visits that is required. As far as a very preterm infant is considered, that is less than 32 weeks or less than 1,500 gram baby is considered, after 3 to 7 days of discharge, preferably after 3 days of discharge, we have to call back the baby to check if the baby has adjusted well in the home environment. Or we can have a home visit also if provision is available. Then every 2 weeks, baby should be called back until a body weight of 3 kg is attained. Then 6, 10, 14-week immunization visits should be covered during these visits. Along with this, 3, 6, 9, 12, 15, and 18. That is 3 monthly interval. Baby should be called back and assessed. Infants with other conditions, they should be called back at least 2 weeks after the discharge, and then according to the immunization schedule, and also at 6th, 9th, 12th, 15, and 18 months of corrected or postnatal age as applicable, and every 6 months until 6, 8 years of age. This is a minimum requirement, and the number of visits can be increased according to the need. For very low birth weights or less than 32 weeks, they should be followed up minimum until postnatal age of 44 weeks for ROP, and by 12 months of corrected age, cognitive or language assessment can be done. By 18 or 24 months of age, till then, by then we can have a better prediction of early school age performance, and at least up to 2 years of corrected age follow-up should be done. It is done in many multi-center networks currently. Place of follow-up, the follow-up place should be easily accessible, direction should be made known, it should be a friendly environment, and all specialties should be made available under a single roof. For low-risk babies, well baby clinics, any pediatrician or primary care physician can do the follow-up. But for moderate risk and high-risk babies, it is better to have a high-risk clinic with a neonatologist and developmental pediatrician along with a multidisciplinary team for the follow-up. This is again emphasizing that we need a multidisciplinary team approach. Now the high-risk follow-up team should involve a neonatologist who is a nodal person who will be doing the overall assessment of the baby and who has working knowledge over all domains. There should be a clinical psychologist who will be doing the developmental evaluation, who manages behavioral and domain-specific problems, and she should be facilitating the development of milestones in all domains. There should be a physiotherapist who will be assessing and grading muscle tone, power, etc., and appropriately planning training for the infant with tone abnormalities. They'll be also prescribing cast and appliances for rehabilitation, etc. Occupational therapists should be there to promote neuromuscular coordination and perceptual skills, fine motor functions, oromotor coordination, etc. And they will be given training in daily activities for the baby. A nutritionist should be there to give counseling regarding complementary feeding and management of infants with failure to thrive and inborn errors in metabolism. There should be a medical social worker who should function, who should act between the family and the follow-up team. An ophthalmologist should be there for follow-up of ROP, visual assessment, and refractory errors. A neurologist should be there for neurological and for treatment of seizures. And and days and timing should be clearly marked on the discharge visit, and they should be counseled regarding when follow-up visits are done, are going to happen. Now, what should be done in follow-up clinics? Before going to that, this is a slide where we have to look at what corrected age, postnatal age, and all what it means. Corrected age is the age of child since expected date of delivery. You can see it in the slide in a better way. After expected date of delivery till the date of assessment is corrected age, and chronological age is from birth to the date of assessment. Post-menstrual age includes the entire gestational age plus chronological age, that is from first day of LMP to the date of assessment is post-menstrual age. Now, as an example, if a preterm baby is born, a 30-weeker baby is born to the nursery at 84 day of life, then the gestational age is 30 weeks. Chronological age is 84 days, that is 12 weeks. PMA would be 42 weeks and corrected age is 2 weeks. And the importance is that chronological age is used for vaccination, for initiating feeding, complementary feeding, and of course to celebrate birthday. And corrected age is mainly used for development assessment and anthropometrical assessment also. Now, plan for follow-up. What all are the things that should be steps that should be kept in mind during a follow-up? First of all, feeding assessment and dietary counseling should be done, and it should be done in all visits. Growth monitoring should be done in all visits. Immunization as per schedule, and it is based on postnatal age also. For ongoing morbidities, it should check in all visits and as and when required. Neurological examination should be done. First, neurological examination is done at third month of age, and then as required. Developmental screening should be done in all visits, but a formal developmental assessment, which can be done by another individual, can be it is done at third month of age. A hearing BERA can be done at third month, and ophthalmological evaluation, ROP screening according to the ROP protocol, USG and MRI according to the need. Now, assessment of feeding and dietary counseling. If the baby is on exclusive breastfeeding, then frequency, duration, and adequacy should be looked for. Supplementary feeding is given, then amount, dilution, and mode of feeding should be taken care of. If the baby is not having adequate weight gain, then any illness for the baby or any maternal problems which interfere with milk output should be taken care of. This is the chart regarding complementary feeding, where you can see at 6 to 8 months, complementary feeding should be started along with breastfeeding, 2 to 3 meals per day. From 9 to 11 months, the number of feeds can be increased as 3 to 4 meals per day. And by 1 year of age, 1 to 2 years of age, breastfeeding can be weaned off, baby can be weaned off, and 3 to 4 meals per day plus snacks in between meals can be given. Growth monitoring, it should be done in all visits. Again, weight, head circumference, and length should be monitored, and it should be plotted in a graph. For preterm babies till 40 weeks of PMA, we use Fenton's chart, which is gender specific. And for term babies and also for preterm babies after 40 weeks, we will be going for WHO MGRS growth charts. Weight and HC should be monitored in all visits, and length should be monitored at least 3 monthly. And for preterm infants, corrected age is used for plotting the growth. Coming to developmental follow-up, developmental screening should be done in all visits, and a formal assessment should be done by at least a third month of age. It can be repeated at 6th, 9th, 18th, and 24 months of corrected age. And regular screening is more important than a single screening. These are the tools which can be used for screening. Random development screening test, TDSC, it can be used from 0 to 2 years of age, and it is a simpler test which has 17 items. Then Denver developmental screening test 2, which is a bit more reliable test, but it is a bit more extensive test which has 123 items, which will be assessing gross motor, language, fine motor, adaptive, and personal social. It also has a behavior rating scale also. Now, this is the random development screening test, where you can see all the 17 items are marked, and the upper and lower limit are given in this thing. It can be even done by a neonatologist itself is not required. It can be even done by a health worker. That is the importance of TDSC. Denver 2, this is the Denver 2 scale. Again, similarly, 123 items are there with upper and lower limit, and it can be plotted and we can assess. And there's also in the right hand side bottom corner, we can see that there is a behavioral assessment also. This can also be used for developmental assessment. Now, additional tools for assessment beyond infancy, beginning at 18 months of age, these all can be used for social and emotional assessment of a baby. Vineland Social Maturity Scale can be used. For behavioral evaluation, CBCL, Child Behavioral Checklist Language Developmental Survey can be used. And for autism evaluation, Modified Checklist of Autism for Toddlers, MCHAT, can be used. This is the example. This is the MCHAT form for autism. In this box, you can see if the MCHAT score is less than 3, no follow-up is required. If it is more than 8, then we have to go immediately go for a diagnostic evaluation and early intervention. And if the score is in between 3 and 7, then follow-up should be done. MCHAT R follow-up, another chart can be used. And in further follow-up, we have to decide whether intervention is required or not. These are a few extra diagnostic tools which can be also used. One is development for development assessment itself. One is development assessment scale for Indian infants. It is an adaptation of Bailey to standardized to Indian population. Then childhood autism rating scale can be also used. Wechsler preschool and primary scale of intelligence can be used, which is basically for IQ assessment. And also Mellon's intelligence scale can also be used, which is also an Indian adaptation for intelligence. Then neurological assessment should be done. Now there are two main ways of assessing neurological state of the baby. One is Hammersmith neonatal neurological examination, which is commonly used in our hospital. It has 34 items assessing tone, motor patterns. We'll be observing spontaneous movements of the baby. The reflexes, visual and auditory attention, and behavior will be assessed. This is the form that we used, the HNNE pro forma that we used. We'll be filling it for all high-risk babies and handing it over to the parents at discharge. Now, Emil-Tyson method. In this method, tone is a fundamental part of assessment, and the tone is assessed according to the gestational age of the baby. That is, from 28 to 40 weeks, a baby has development of tone in chordocephalic way, and from 40 weeks onwards, it follows cephalocaudal way. So, according to the gestation, according to the age of the baby, the tone should be assessed. And tone is evaluated under 3 headings. One is spontaneous posture, then posture of the baby, passive tone, which is assessed by looking at the angles and extremities with a goniometer, and also the active tone. This is the angles which are measured in passive tone measurement. We'll be seeing the scarf sign. The pictures show a scarf sign, the adductor angle, dorsiflexion angle, and popliteal angle. According to the month, the normal values are given, and if it does not correspond, it is considered to be abnormal. 0 to 3 months, adductor angle is 40 to 80 degree. 4 to 6 months, it will be 70 to 110 degree. From 7 to 9 months, it is 110 to 140 degree. And from 10 to 12-month-old babies, it is 140 to 160 degree. When we consider popliteal angle, 0 to 3 months, it is 80 to 100 degree. 4 to 6 months, 90 to 120. 7 to 9 months, 110 to 160. And 10 to 12 months, 150 to 170. Dorsiflexion, 0 to 3 months, 60 to 70 degree. 4 to 6 months, 60 to 70. Again, it will be 60 to 70 degrees itself. And scarf sign, from 0 to 3 months, elbow does not cross the midline. From 4 to 6 months, it crosses midline. And to 9 months, it goes beyond the axillary line. The assessment in Emil-Tyson, apart from tone, neurosensory hearing and vision is assessed. Neurobehavioral pattern is assessed, where arousal pattern, quality of cry, suckling and swallowing is assessed, and head growth, where head circumference, sutures and size of the anterior fontanelle leg are also assessed for. And any hypertonia or hypotonia should be looked for. Asymmetry between extremities should be recorded, and any history of seizures or involuntary movement should be looked for. This is neurological signs which suggest of increased risk of CP. That is abnormal tone in limb, neck, or trunk. It has 12 to 15-fold of risk to have CP in future. If there is diminished cry for more than 1 day, the baby will be having a 21 times higher risk to have CP. Weak or absent suck has 14-fold risk. need for OG feeding will lead to 16 to 22 times increases for CP in future. And if there's diminished activity for more than 1 day, there's 19-fold risk to have CP in future. Now, mild to moderate, one thing, the thing to be kept in mind is that mild to moderate abnormalities may improve with time, and that this phenomenon is called transient neuromotor dysfunction. The reason is that the brain, there is high brain plasticity in infants, and they may become normal in future. Head circumference is the most important tool for detecting abnormal brain growth in neonates during follow-up. And to be kept in mind is that structured age-appropriate neuromotor assessment should be performed according to the corrected age, at least once during the first 6 months, and once during the second 6 months, and once yearly later on. Then coming to vision assessment just merely doesn't mean ROP. ROP checkup should be done, which should start in NICU until 44 weeks of PMA. Apart from that, there should be assessment of squint, vision, cataract, and optic atrophy. During follow-up to the parents, ocular history should be asked, whether you think the child is able to see well, whether the child hold objects close to her eyes while focusing. Do parents find child's eyes straight? Is there any evidence of strabismus? Do they seem to cross? Do the eyes seem to cross, or do they appear hazy? Do the eyes appear unusual to the parents in any way? It should be asked. And then visual assessment, how it is done by basically looking whether the baby can fix and follow an object. Assessment has to be made in both eyes together, binocularly and then separately. If there is poor fixation and following binoculars after 3 months, then we have to suspect a bilateral eye or brain abnormality. External evaluation of different eye structures and ocular alignment should be also checked. Strabismus should be checked. Pupils and red reflex should be also checked. And the formal assessment of visual acuity should be also done at 9 months of age. It is a quite underrated thing, but it should be also done. A Cardiff or Teller acuity card should be used, or a Leah grating acuity test can be used. The picture shows a Leah grating acuity test where the visual acuity can be checked. It should be also done, checked in ROP babies also, because there is high risk of myopia of prematurity. Early rehabilitation for visual impairment should be done so that the child gets appropriate stimulation. Hearing assessment, again, high-risk infants have a higher incidence of moderate to profound hearing loss. It is 2.5 to 5% in prevalence compared to normal babies. Normal babies will be having 1%. Now, in infants without any risk factors, OA can be used for screening. But for high-risk newborns, we require automated auditory brainstem response, or AABR, for screening. Those who fail, it should be done in multiple steps. Those who fail on first screen, they can be re-screened prior to discharge to minimize false positivity rates. Those failing in second screen also should get a diagnostic BERA done after 3 months of age. For premature infants, hearing screen is done after 34 weeks of PMA to decrease false positive results. To be kept in mind is that even after 2-stage screening followed by AABR pass, incidence of premature hearing loss has been found to be significant. Hence, it is important to continue hearing follow-up clinically in the follow-up visits. Now, coming to the role of neuroimaging. Neuroimaging is important with regard to three categories of babies: for preterm newborns, for term babies with asphyxia, and for term babies with bilirubin encephalopathy. For preterm babies, a routine USG cranium should be done for all babies less than 32 weeks at postnatal age 7 to 14 days and between 36 to 40 weeks of PMA. For term babies with asphyxia, conventional T1, T2 and diffusion-aided MRI scans can help in diagnosis to assess the time of insult, and it can also give us an idea regarding the outcome of the baby. Then late MRI from day 8 to 30 has a higher sensitivity than early MRI, day 1 to 7. So it is better to do a late MRI. Then for term infants with bilirubin encephalopathy also, MRI brain is advised once the baby is stable. Now coming to early intervention, this is a group where you can see the interventionist is having a dummy, and parents are taught how to do physiotherapy and all, and they're having a parental meeting also. The parent training programs will be also done. This is a another picture which is given in RBSK guidelines, where how a follow-up center should be. This is an early intervention room which has all the play material and all the diagnostic tools which are required. This is the picture of an ideal early intervention room. Now, why should we give an early intervention? The first 24 months of a baby is crucial. Timing of intervention becomes important when a child runs the risk of missing an opportunity to learn when they have maximum readiness. In any developmental stage, a child may have difficulty in learning a particular skill, and only through early identification and appropriate programming can children develop their early potential. The aim of early intervention is to initiate management early, thus minimizing the progression of any developmental delay to disability. And if the disability is established, then the aim of early intervention would be to prevent progression towards handicap that may arise among children without intervention. Now, why developmentally supportive care is required? We have to give an appropriate stimulus. Only an appropriate stimulus can promote inputs which can modulate pathways and it can prevent altering the programmed brain growth also. Now, developmentally supportive care, it should ideally start in the NICU or SNCU. How can it be done? The steps which can be taken include by optimizing the lighting, by reducing the noise. We can club all the painful procedures together, and during the procedure itself, we can allow the baby sucking sucrose or breast milk. We can hold the hand of the baby. Then tactile stimulation can be done by gentle touch, gentle massage, etc. can be given. KMC should be given. Non-nutritive sucking can be advised. Passive exercises should be given to the baby. And coming to community early intervention program, the steps which are to be done in a community grade. This is something which has to be followed in a community, in a district center or district early intervention center, etc. Screening by parents and families can be done, and screening can be done. It will be done by a health worker also. Later, an evaluation will be done by the pediatrician, and the pediatrician can give individualized intervention plan to the therapist, and it can be advised to the family also. Then monitoring and evaluation of the baby should be done, and home-based rehabilitation program will be also done in community level. This is the district early intervention center. This DEIC is something which is attached to district hospitals, where follow-up of newborns of all born in the district level, in the district hospital level, will be followed up. This is the register which is maintained there. Yes, thus we come to the end of the presentation. Now, regarding take-home messages, one is that all health facilities caring for sick neonates, they should have a structured follow-up program with a multidisciplinary team, so that we can aim for intact survival. Early intervention program must be started, and it should start in NICU once the neonate is medically stable. Prior to discharge, a detailed medical and neurological assessment, a neurosonogram, ROP screen, and a hearing screen should be initiated. The follow-up protocol should include the assessment of growth, nutrition, development, vision, hearing, and neurological status. Formal development assessment should be performed at least once in first year and repeated yearly thereafter till 6 years of life. And ideally, the follow-up should continue till late adolescence and minimum at least till school age of the child. Thank you.
Thank you, Dr. Lekshmi, for telling us the journey of a follow-up of a high-risk baby. So, all of you are going to follow up the babies, even if you are not taking care of high-risk babies, at least low-risk babies in terms of normal units who fall into the low-risk categories. All of you will be definitely taking care of them. So, for residents specifically, like once you finish your MD Pediatrics, so if you are taking care of any preterm baby or any moderate or high-risk babies, remember that your job doesn't end by just salvaging that baby or making him to survive in ICU. Your job is half done if you don't take care of the follow-up part. Now, those who are not going to see high-risk babies, only going to focus only on the low risk, my humble request to all of you is that all of you see babies at 6 weeks of age. That is an opportunity where you can pick up eye and hearing issues. A lot of time we just look at the vaccination part and just ask breastfeeding, but we never, and of course in examination we just put our stethoscope, look at the murmur and then finish our examination. So please ensure that during those visits of a normal newborn, at least try to look at vision part and hearing part. These are two important things. If you miss at that time, then there will be a delay in picking up the things, and by the time you start intervening, you know that earlier you intervene, the better the results. So if you miss that opportunity, and fortunately or unfortunately, it is a pediatrician. If we are missing at that point in terms of vision deficits or hearing deficits, then I think the onus lies on us to improve ourselves to pick up those things. So before I invite questions, I would like to invite Arun sir, who is an expert in this area, in follow-up for his expert comments, and then we'll take up the questions. Sir, please.
Thank you, everybody. And I think that first of all, I must say that Dr. Lakshmi has done a good job in trying to reflect the importance of this. My only two questions, it is not questions, but I would say suggestions. Like, first of all, we think that follow-up is required only for sick newborns. Follow-up is required for all newborns. Please understand, the aim of follow-up is to improve the cognitive ability of a child. So even normal newborns, and in the first 6 months of developmental trajectory, it is the genetical part, it is the intrauterine environment which makes the trajectory of the development in the first 6 months. But beyond 6 months, the trajectory is also decided by the extrauterine environment. And in a country like ours, even if that child never went to an NICU, but belongs to a poor family where no one has time, then you find that the developmental milestones till 6 months they are okay, but after 6 months they start getting delayed, which is entirely due to the external environmental reasons. And hence I would say number one is that follow-up is required for all children. Second is, there is another message to this follow-up. If I see that children from my unit are having more vision problems, more hearing problems, then I should go back and think, can I change the way the child is kept within the hospital? Can I change the hospital environment? So there is another value of this follow-up, that you study it and try to change the way you treat. And that can also make a change, because most of the studies have shown two things. That the longer the newborn or a child stays in hospital, the more affected is his neurodevelopmental outcome. So when this study was done in all over Europe, that for the same gestational age, for the same problems, the length of stay for every newborn was separate in separate hospitals. And when then they saw the effect of that stay on the child, you will be surprised to know. So the message is also that we should know that while we are addressing a problem, while we are focusing on a problem, every day extra in the hospital actually can impact the neurodevelopmental outcome. And my last word is that supposing a newborn has a congenital heart disease, do we expect that there will be developmental issues even if his MRI brain is normal? A child has been operated for a gut surgery. Do we expect that he will have a developmental issue? If yes, then should we subject all children to a neurodevelopmental evaluation even after a successful surgery. So I think these are things more to be thought in the broader aspect of it. But I think it is a very good way to start thinking that development is a serious component, because development is equivalent to the cognition of the child, and that is equivalent to a nation's cognitive ability to deal with the problem. Thank you. Any questions you can ask?
So I know that there is a meeting at 4 o'clock. So if there are some questions, so we can take up quickly if there are any questions. We still have 4 or 5 minutes. If anyone has any kind of query. So I think there are none, then we close the session. Thank you everyone for joining. Yeah, sorry. Please go ahead.
Yeah, any plan to for just like a neuro rehabilitation program? Just we are creating just an neonatology follow-up to coordinate the PMR or other specialties like psychology in the neuro rehabilitation program in our OPD area only.
So right now we had made an attempt that during our follow-up clinics before the COVID lockdown, so the PMR team used to sit with us. So they always used to send 2 people from their side, physiotherapist or OT, and sometimes their consultant also used to sit with us. And simultaneously, we requested the ophthalmology department to have their ROP screens on the same day, on the Wednesdays, so that the patient comes in the morning, they get their ROP screens on the same day, and in the afternoon show it to us. The idea was that if you try to decrease the number of visits by giving them everything on the same day, under the same roof, then the compliance rate improves, which we wanted.
Yes, sir.
So this we made an attempt, and that was running successfully before this COVID lockdown. And then I think the things will again restart in the same manner very soon. Simultaneously, yeah, please go ahead.
Yeah, one time in complete discussion with Kuldeep sir, we can make some video of the newborn physiotherapy or neuro rehabilitation program, and we can provide CD or such like, so parents can follow and can utilize them. Video.
I agree that video needs to be made, but I think there is a catch here. If you discuss with the PMR team, truly speaking, each baby needs an individual assessment to begin with.
Yes.
Because the degree of deficit may be different, the kind of intervention which may be required may be different. So it's like single shoe fitting everyone's foot. I really doubt that is right, because it may, to some extent, it may be right, but then it will be difficult that without assessing and then directly giving those kind of exercise. So I think one assessment is important, and then once the OT, occupational therapist or physiotherapist, is teaching the parent, at that time they can make a video, and then the same thing gets practiced at home, and after 6 weeks or 8 weeks, again they reassess now what kind of exercises are required. So as a broad thing, we can try to make a module, I agree, which is required, but then I think individual assessment is also required, because if the stimulation is given in a wrong way, it can create more issues rather than giving them.
So
but yes, broad principles wise, broad module wise, I think one can, it's worthwhile.
But some step are always follow, sir. Most of the time, some simple step, just like joint movement or some things, or just like educational video, how to detect child is hearing or not hearing, how to parents can notice the child is which vision is there or not.
I think those things are very nicely described in the RBSK, this mother-child card. If you see, very nice photographs have been made for assessing the development, the feeding. I think that's very important. Most of our residents never look at this, which I have found in while attending OPDs. So those things are very nicely described here. So both in the English and Hindi versions of the card. But yes, if we can further add on to those things.
Okay, sir.
Any suggestions or any other comments?
Same we previously discussed in development कि physiotherapy should be start child when the first admission there. Neurorehabilitation from the day one, as soon as we can, child is stable and can utilize. So every resident should insist on neurorehabilitation on every patient contact.
Agreed.
Either it may be IPD or OPD.
That standard of care and which is being practiced here also in our ICU. So as soon as the babies become stable, the kangaroo mother care is started, which is for low birth weight babies. So that is again a kind of stimulation, and then the PMR team also takes over and they start exercises to the parents. Which is started.